Welcome to this video entitled, Ventilator-Associated Pneumonia. As a way of introduction, ventilator-associated pneumonia, abbreviated as VAP, is the most frequent intensive care unit-acquired infection among patients who are treated with mechanical ventilation. In contrast to infections of other organs, e.g., urinary tract and skin, for which mortality ranges from 1 to 4%, the mortality rate for ventilator-associated pneumonia, defined as pneumonia developing more than 48 hours after the onset of mechanical ventilation, ranges from 20 to 50%, and can even be higher when lung infection is caused by high-risk pathogens. Although the attributable mortality rate for ventilator-associated pneumonia is still debated, good evidence indicates that ventilator-associated pneumonia prolongs the duration of mechanical ventilation and of the ICU stay. Approximately 50% of all antibiotics prescribed in an ICU are administered for true or supposed respiratory tract infections. Because several studies have shown that appropriate antimicrobial treatment of patients with ventilator-associated pneumonia significantly improves outcome, rapid identification of infected patients and accurate selection of antimicrobial agents are important clinical goals. Agreement is lacking, however, about the appropriate diagnostic, therapeutic, and preventive strategies for ventilator-associated pneumonia. We will now discuss the pathogenesis of ventilator-associated pneumonia. Multiple defense mechanisms protect the normal human respiratory tract from infection. Examples include anatomic barriers, such as the glottis and larynx, cough reflexes, constituents of tracheobronchial secretions, mucociliary clearance, epithelial lining fluid and surfactant components, cell-mediated and humoral immunity, a phagocytic system that involves alveolar macrophages and recruited neutrophils, and both humoral and cell-mediated adaptive immunity. When these coordinated components function properly, invading microbes are eliminated and clinical disease is avoided. When these defenses are impaired, or if they are overcome by a high inoculum of organisms or organisms of unusual virulence, pneumonitis results. As suggested by the infrequent association of ventilator-associated pneumonia with bacteremia, most of these infections appear to result from aspiration of potential pathogens that have colonized the mucosal surfaces of the oropharyngeal airways, the dental plaque, and/or the paranasal sinuses. Endotracheal intubation not only compromises the natural barrier between the oropharynx and trachea, it also facilitates the entry of bacteria into the lungs by pooling and leakage of contaminated secretions around the endotracheal tube cuff from the subglottic area to below the true vocal cords. Contaminated secretions leak into the lungs of most intubated patients and may be facilitated by the supine position. Moreover, biofilm formation on the inner and outer surfaces of the endotracheal tube provides a protected environment for pathogens. Bacterial aggregates in biofilm dislodged during suctioning are dangerous for the lung because they are difficult to clear by host immune defenses and difficult to eradicate with antibiotics. Tracheobronchial colonization with gram-negative bacilli, abbreviated as GNB, usually precedes the onset of ventilator-associated pneumonia. Risk factors for tracheobronchial colonization appear to be the same as those that favor pneumonia, and include advanced age, more severe illness, longer hospitalization, prior or concomitant use of antibiotics, malnutrition, endotracheal intubation, depressed level of consciousness, immune suppression from disease or medication, azotemia, underlying pulmonary disease, and longer duration of mechanical ventilation. Experimental studies have linked some of these risk factors with changes in adherence of gram-negative bacilli to respiratory epithelial cells. Although formally attributed to protease-induced changes in epithelial cell surface proteins, these changes in adherence also reflect alterations of cell surface carbohydrates. Bacterial adhesins and prior antimicrobial therapy appear to facilitate the process. Interestingly, Enterobacteriaceae usually appear first in the oropharynx, whereas Pseudomonas aeruginosa more often appear first in the trachea. Although the stomach can be a reservoir for potential pneumonia pathogens, the gastropulmonary route of infection is not the primary route of infection in most critically ill patients. Progression of colonization from the stomach to the upper respiratory tract with subsequent episodes of ventilator-associated pneumonia could not be demonstrated in several studies, and efforts to eliminate the gastric reservoir with antimicrobial therapy without decontaminating the oropharyngeal cavity have generally failed to prevent ventilator-associated pneumonia. In fact, there is more than one potential pathway for colonization of the oropharynx and trachea in such a setting, including cross-infection from the hands of healthcare personnel and contaminated respiratory therapy equipment. Patient care activities, such as bathing, oral care, tracheal suctioning, enteral feeding, and tube manipulations, provide many opportunities for transmission of pathogens when meticulous infection control practices are not followed. We will now discuss the epidemiology of ventilator-associated pneumonia. Let's begin with the incidence. The exact incidence of ventilator-associated pneumonia varies widely depending on the case definition of pneumonia and the population being evaluated. For example, the incidence of ventilator-associated pneumonia may be up to 2 times greater in patients when the diagnosis is made by qualitative or semi-quantitative sputum cultures rather than by quantitative cultures of lower respiratory tract secretions. However, studies have confirmed that nosocomial pneumonia is considerably more frequent in ventilated patients than in other ICU patients, with the incidence being as much as 6-fold to 20-fold higher in ventilated patients than in non-ventilated patients. Ventilator-associated pneumonia manifests in 9 to 27% of all intubated patients, and its incidence increases with duration of intubation. The risk of ventilator-associated pneumonia is highest early in the course of the hospital stay, estimated to be 3% per day during the first 5 days of intubation, 2% per day during days 5 to 10 of intubation, and 1% per day after day 10.7 because most mechanical ventilation is short-term. Approximately half of all episodes of ventilator-associated pneumonia develop within the first 4 days of mechanical ventilation. In a large epidemiologic study, independent predictors of ventilator-associated pneumonia determined by multivariate analysis were primary admitting diagnosis of burns, trauma, central nervous system disease, respiratory disease, or cardiac disease, mechanical ventilation during the preceding 24 hours, witnessed aspiration, and use of paralytic agents. Exposure to antibiotics conferred protection, but this effect was attenuated over time. According to 4 studies, the ventilator-associated pneumonia rate was higher in patients with acute respiratory distress syndrome, abbreviated as ARDS, than in other ventilated patients, affecting between 34% and more than 70% of patients with acute respiratory distress syndrome and often leading to the development of sepsis, multiple organ failure, and death. Attributable mortality, morbidity, and costs in mechanically ventilated patients in the ICU. Those with ventilator-associated pneumonia appear to have a 2-fold to 10-fold higher risk of death than those without pneumonia. Although these statistics indicate that ventilator-associated pneumonia can be lethal, previous studies have not clearly demonstrated that pneumonia is responsible for the higher mortality rate of these patients. It is often difficult to determine whether ICU patients with severe underlying illness would have survived if they had not developed ventilator-associated pneumonia. Ventilator-associated pneumonia, however, has been recognized in several case control studies or studies using multivariate analysis as an important prognostic factor for different groups of critically ill patients. Based on a multi-state progressive disability model that appropriately handled ventilator-associated pneumonia as a time-dependent event in a high-quality database of 2,873 mechanically ventilated patients, ventilator-associated pneumonia attributable mortality was found to be 8.1% overall. These results are consistent with those obtained in other observational studies using also multi-state models and causal analysis, detecting a relatively limited mortality attributable to ventilator-associated pneumonia. Other factors beyond the simple development of ventilator-associated pneumonia, such as the severity of the disease, the adequacy of antimicrobial therapy, or the responsible pathogens, may be more important determinants of outcome for patients in whom pneumonia develops. Indeed, it may be that ventilator-associated pneumonia increases mortality only in the subset of patients with intermediate severity of illness, in those for whom initial treatment is inappropriate, and/or in patients with ventilator-associated pneumonia caused by high-risk pathogens, such as Pseudomonas aeruginosa. Patients with very low severity and early onset pneumonia caused by organisms such as Haemophilus influenza or Streptococcus pneumoniae have excellent prognoses with or without ventilator-associated pneumonia, whereas very ill patients with late onset ventilator-associated pneumonia would be unlikely to survive. Studies have clearly shown that patients with ventilator-associated pneumonia have prolonged duration of mechanical ventilation and lengthened ICU and hospital stay than do patients who do not have ventilator-associated pneumonia. Summarizing available data, ventilator-associated pneumonia appears to extend the ICU stay by at least 4 days, with the attributable ICU length of stay being longer for medical than surgical patients and for patients infected with high-risk rather than low-risk organisms. The prolonged hospitalization of patients with ventilator-associated pneumonia underscores the considerable financial burden imposed on the healthcare system by the development of ventilator-associated pneumonia. Etiologic agents. Microorganisms responsible for ventilator-associated pneumonia differ according to geographic areas, characteristics of the ICU patients, durations of hospital and ICU stays before onset of the disease, and risk factors for multidrug resistant (MDR) pathogens. However, multiple studies have shown that gram-negative bacilli, particularly Pseudomonas aeruginosa and Enterobacteriaceae, cause many of the respiratory infections in this setting, with relatively minor changes in the distribution of the pathogens during the last decade. Although ventilator-associated pneumonia typically involves infection with a single pathogen, polymicrobial infections are also common. Until recently, multi-drug-resistant pathogens were isolated more frequently in late-onset ventilator-associated pneumonia cases than in early-onset, within 4 days of hospital admission, cases, mostly reflecting prior use of broad-spectrum antibiotics in these patients. However, several later studies found similar rates of etiologies in patients with early and late-onset ventilator-associated pneumonia, emphasizing that the local ICU ecology is the most important risk factor for acquiring multidrug-resistant pathogens, irrespective of the length of intubation. Extended-spectrum beta-lactamase producing Enterobacteriaceae, abbreviated as ESBLPE, are increasingly encountered in patients with hospital-acquired infections, including ventilator-associated pneumonia, with additional mortality and cost. They now represent 19 to 61% of the episodes caused by Enterobacteriaceae, varying according to species and to countries. Systematic screening of extended-spectrum beta-lactamase producing Enterobacteriaceae fecal carriage may help to guide initial therapy in patients with ventilator-associated pneumonia when cultures are negative, because they have a very good negative predictive value for subsequent extended-spectrum beta-lactamase producing Enterobacteriaceae infections. Conversely, a positive specimen only has a predictive value from 35 to 40% and thus does not imply that initial antimicrobial therapy should systematically cover this pathogen. Tracheal colonization with Pseudomonas aeruginosa increases with increased length of hospitalization, prior antibiotic use, and severity of illness, and is an important risk factor for ventilator-associated pneumonia caused by this microorganism. In one study, the odds of developing Pseudomonas aeruginosa ventilator-associated pneumonia were 8 times higher in patients with prior Pseudomonas aeruginosa colonization than in non-colonized patients, confirming that screening for Pseudomonas aeruginosa tracheal colonization by biweekly active surveillance cultures could reliably exclude the need for targeting this microorganism when cultures are negative for this microorganism. Acinetobacter baumannii is also a common cause of ICU-acquired infection, accounting for 8 to 14% of ventilator-associated pneumonia in the United States and Europe, but much higher rates, 19% to greater than 50%, in Asia, Latin America, and some Middle Eastern countries. Importantly, many isolates are now resistant to all antimicrobials except colistin, also called polymyxine E, and tigecycline, and some infections are resistant to these antimicrobial agents as well. The emergence of infections caused by carbapenem-resistant Enterobacteriaceae, abbreviated as CRE, worldwide represents another alarming problem, although the prevalence of such infections is highly variable across different countries. Prior use of carbapenems and prior hospitalization in a country where carbapenem-resistant Enterobacteriaceae is highly prevalent have been reported as independent risk factors for the acquisition of carbapenems-producing Enterobacteriaceae and other carbapenem-resistant Enterobacteriaceae. Legionella species anaerobes, fungi, viruses, and even Pneumocystis jirovecii are also potential causative agents, but these microbes are not commonly found when pneumonia is acquired during mechanical ventilation. Several of these causative agents, including viruses, might be more common than reported because they are difficult to identify. Isolation of fungi, most frequently Candida species, poses interpretative problems. Invasive disease has been reported in ventilator-associated pneumonia, but yeasts are isolated frequently from respiratory tract specimens in the absence of apparent disease. The use of the commonly available respiratory sampling methods, bronchoscopic or non-bronchoscopic, in ventilated patients is not sufficient to make the diagnosis of Candida pneumonia, and evidence of lung tissue invasion is also needed. We will now discuss the diagnosis of ventilator-associated pneumonia. Ventilator-associated pneumonia is typically identified at the bedside by combining 3 criteria. 1. Clinical observations suggesting infection, such as the new onset of fever, purulent sputum, leukocytosis, increased minute ventilation, arterial oxygenation decline, and/or the need for increased vasopressor infusion to maintain blood pressure. 2. new or progressive persistent radiographic opacities. And 3. Positive, microbiologic culture results for a potentially pathogenic microorganism isolated from tracheal aspirates, bronchoalveolar lavage, BAL, fluid, pleural fluid, and/or blood. However, this definition of ventilator-associated pneumonia is frequently inaccurate and leaves room for subjective interpretation. Because a new pulmonary opacity is the only criterion confirming involvement of the intra-alveolar pulmonary spaces by the infectious process, it is considered a prerequisite for the diagnosis of ventilator-associated pneumonia. However, most of the time it is not present, with the infection remaining confined to an already abnormal region of the lung. Thus, it is mandatory to consider the diagnosis of ventilator-associated pneumonia in patients who deteriorate clinically, and/or in whom vasopressors need to be increased in order to maintain blood pressure, even in the absence of a clear-cut progression of radiographic abnormalities. The presence of a pathogen at the level of the proximal airways does not suffice for making the diagnosis of ventilator-associated pneumonia, because most ventilated patients are colonized with pathogens very early after the initiation of mechanical ventilation. Even deciding which threshold should be applied to define positive culture when using semi-quantitative or quantitative tracheal aspirate or BAL fluid cultures can be challenging, especially for specimens obtained after starting new antibiotics. Thus, the absence of indisputable reference standards continues to fuel controversy about the adequacy and relevance of many studies in this field and has led investigators to describe other types of lower respiratory tract infection, such as ventilator-associated tracheobronchitis, or even to abandon the concept of ventilator-associated pneumonia and replace it by a new construct that comprises different levels of ventilator-associated events, including infection-related ventilator-associated condition. In practice, either of two conceptually different diagnostic strategies can be used when ventilator-associated pneumonia is suspected. Current evidence is insufficient to favor either approach to diagnosis of ventilator-associated pneumonia regarding clinical outcomes, although evidence indicates that the second, invasive, approach can reduce use of antibiotics. The first strategy is to treat every patient clinically suspected of having a pulmonary infection with new antibiotics, even when the likelihood of infection is low, arguing that several studies showed that immediate initiation of appropriate antibiotics is associated with reduced mortality. The second strategy is to use an invasive diagnostic approach based on quantitative cultures of distal lower respiratory tract, abbreviated as LRT, specimens obtained using bronchoscopic or non-bronchoscopic techniques, such as BAL or a protected specimen brush, to improve the identification of patients with true ventilator-associated pneumonia and facilitate decisions about whether or not to treat with antibiotics. Although no consensus exists on the best diagnostic strategy for patients clinically suspected of having ventilator-associated pneumonia, the goal of each strategy is to institute early appropriate antibiotic therapy in patients with true ventilator-associated pneumonia and to withhold it in others. We will now discuss the clinical diagnostic strategy. With the clinical strategy, all patients suspected of having ventilator-associated pneumonia are treated with antibiotics that they have not received recently. The selection of appropriate empirical therapy is based on risk factors and local microbiologic and resistance patterns and involves qualitative testing to identify possible pathogens. The initial antimicrobial therapy is adjusted according to culture results or clinical response, as shown in Figure 49.1. Antimicrobial treatment is discontinued only if the following three criteria are fulfilled on day 3. 1. Clinical diagnosis of ventilator-associated pneumonia is unlikely. There are no definite opacities found on chest radiography at follow-up, and no more than one of the three following findings is present: temperature greater than 38.3 degrees Celsius, leukocytosis or leukopenia, and purulent tracheobronchial secretions, or an alternative non-infectious diagnosis is confirmed. 2. Tracheobronchial aspirate culture results are non-significant. And 3. Severe sepsis or shock is not present. This clinical approach has two undisputable advantages. First, no invasive and/or specialized diagnostic procedures, such as fiber optic bronchoscopy, BAL, and quantitative microbiologic techniques are required, and, second, the risk of missing a patient who needs antibiotic treatment is minimal when all suspected patients are treated with new antibiotics. The disadvantages include the potential sampling errors inherent in specimens obtained from the proximal airways and lower specificity for distinguishing airway colonization from true pneumonia. Slightly different variants of the clinical approach, including the use of quantitative or semi-quantitative cultures of endotracheal aspirates for defining a positive result, have been described to increase specificity and avoid undue prolongation of antibiotic therapy. While the simple qualitative culture of tracheal aspirates is a technique with a high percentage of false positive results, several studies suggest that the diagnostic accuracy of quantitative cultures is similar to the accuracy of more invasive techniques, limiting the risk of overusing antibiotics in patients with colonized proximal airways and/or a mild form of tracheobronchitis but no true pneumonia. Another option when using the clinical approach is to follow the strategy described by Singh and colleagues, in which decisions regarding initial antibiotic therapy are based on a clinical score constructed from 7 variables, the Clinical Pulmonary Infection Score, abbreviated as CPIS. Patients with a clinical pulmonary infection score greater than 6 are considered to have ventilator-associated pneumonia and are treated with antibiotics for 10 to 21 days. If the clinical pulmonary infection score is 6 or less, antibiotics are discontinued after 3 days, as shown in Figure 49.2. Such an approach avoids prolonged treatment of patients who have a low likelihood of infection while allowing immediate treatment of patients who are more likely to have ventilator-associated pneumonia. Antibiotics can also be stopped very early in patients with suspected ventilator-associated pneumonia, but minimal and stable ventilator settings. These patients may not have pneumonia at all, or they may have comparatively mild pneumonias that can be adequately treated with very short courses of antibiotics, 1 to 3 days. Pause the video and carefully scrutinize Figure 49.1, illustrating the clinical diagnostic strategy before advancing to the next slide. Pause the video and carefully scrutinize Figure 49.2, illustrating the clinical diagnostic strategy guided by a clinical score before advancing to the next slide. We will now discuss the invasive diagnostic strategy. With the invasive strategy, direct microscopic examination and quantitative cultures of LRT secretions obtained using BAL, performed with or without a bronchoscope, are used to define both the presence of pneumonia and the etiologic pathogen. Growth above a threshold concentration is required to make a diagnosis of ventilator-associated pneumonia and determine the causative microorganisms. Growth below the threshold is assumed to be due to colonization or contamination. Using this strategy, therapeutic decisions are made according to a strict protocol, using the results of direct examination of distal pulmonary samples and results of quantitative cultures in deciding whether to start antibiotic therapy, which pathogens are responsible for infection, which antimicrobial agents to use, and whether to continue therapy, as shown in Figure 49.3. Quantitative cultures of BAL specimens consistently yield a lower frequency of positive results, based on a quantity of microorganisms above the diagnostic threshold, than are obtained when only qualitative cultures of tracheal aspirates are used. Thus, when therapeutic decisions are based on these data, fewer patients are treated with antibiotics and a potentially narrower spectrum of therapy is used than when using the clinical approach, thereby limiting the emergence and dissemination of drug-resistant strains and antibiotic toxicity. Another compelling argument in favor of the invasive strategy is that this approach directs attention away from the lungs as the source of fever when BAL quantitative culture results are negative. Many ICU patients with negative bronchoscopic cultures have other sites of infection, such as wounds, the urinary tract, or intravascular catheters that need to be identified to avoid delays in initiating appropriate treatment. The accuracy of quantitative cultures of lower respiratory tract secretions obtained using BAL is questionable in patients who have received prior antibiotics, particularly when new antibiotics are introduced after the onset of the symptoms suggestive of nosocomial pneumonia and before pulmonary secretions are collected. In that case, the newly initiated antibiotics can increase the number of false negative results, regardless of the way in which the secretions are obtained. One major technical problem with all bronchoscopic techniques is proper selection of the sampling area in the tracheobronchial tree. The sampling area is usually selected based on the location of the radiographic opacity or on the bronchoscopic identification of a pulmonary segment that has purulent secretions. In patients with diffuse pulmonary opacities or minimal new changes in a previously abnormal chest radiograph, determining the correct segment to sample can be difficult. In such cases, sampling should be directed to the area where endobronchial abnormalities are maximal. Because autopsy studies indicate that ventilator-associated pneumonia frequently involves the posterior portion of the right lower lobe, this area should probably be given priority for sampling. Pause the video and carefully scrutinize Figure 49.3, illustrating the invasive diagnostic strategy before advancing to the next slide. E will now discuss a summary of the evidence. Aside from decision analysis studies and a single retrospective study, 5 trials to date have used a randomized scheme to assess the effect of a diagnostic strategy on antibiotic use and outcome in patients suspected of having ventilator-associated pneumonia. No differences in mortality and duration of mechanical ventilation were apparent by analysis of pooled data. However, in a randomized study of 413 patients, those managed with an invasive strategy that combined quantitative cultures of BAL specimens with an algorithm for treatment de-escalation had a significant increase in antibiotic-free days at day 14, that is 5 versus 2.2, and day 28, that is 11.5 versus 7.5, compared with non-invasive methods using qualitative cultures, clearly indicating a decrease in antibiotic exposure. Several prospective studies have also concluded that antibiotics can be stopped in patients with negative quantitative cultures, without adversely affecting the recurrence of pneumonia and mortality. Although no consensus has yet been reached on appropriate diagnostic strategies for ventilator-associated pneumonia, the authors of the recent European Guidelines on Hospital-Acquired Pneumonia or Ventilator-Associated Pneumonia suggest obtaining lower respiratory tract quantitative samples prior to any antibiotic treatment, to reduce antibiotic exposure in stable patients with suspected ventilator-associated pneumonia and to improve the accuracy of the results. Weak recommendation, low quality of evidence. Because BAL removes cells, approximately 1 million, and secretions from a large lung area, and samples can be examined microscopically immediately after the procedure to verify the presence or absence of intracellular or extracellular bacteria in the lower respiratory tract. This examination is particularly useful and well adapted to allow rapid identification of an infection having reached the distal bronchioles and the intra-alveolar spaces. As such, our own position is to recommend the use of a strategy based on systematically performing BAL in all patients clinically suspected of having ventilator-associated pneumonia. If BAL performed with or without a bronchoscope is not available, results of tracheal aspirate quantitative cultures can be used as an acceptable substitute, provided that a sufficiently high threshold, i.e., equal to or greater than 10 power 5 colony-forming units per milliliter, is applied, to avoid overusing antibiotics in patients with only proximal airway colonization. Whether the diagnosis of ventilator-associated pneumonia can be improved by lung ultrasonography and/or new methods for identifying and quantifying the bacterial burden present in the lower respiratory tract warrant investigation. A growing number of rapid diagnostic techniques using biomolecular approaches, including quantitative and multiplex polymerase chain reaction, matrix-assisted laser desorption ionization time of flight mass spectrometry, abbreviated as MALDI-TOFMS, peptide nucleic acid fluorescence in situ hybridization, and morphokinetic cellular analysis using advanced optics microscopy, are available that allow early pathogen identification and determination of antimicrobial susceptibility. These new technologies, when coupled with strong antibiotic stewardship programs, are expected to reduce the time to appropriate antimicrobial therapy in patients infected with multi-drug resistant pathogens, as well as avoiding broad-spectrum regimens when the infection can be treated by a narrow-spectrum antibiotic, but these assays remain susceptible to the problems of contamination and colonization. Pause the video and carefully scrutinize Table 49.1 summarizing proposed strategy for managing antimicrobial therapy in patients with ventilator-associated pneumonia before advancing to the next slide. Next we will discuss the treatment of ventilator-associated pneumonia. Antimicrobial therapy of patients with ventilator-associated pneumonia is a two-stage process. The first stage involves administering broad-spectrum antibiotics to avoid inadequate treatment of patients with true bacterial pneumonia. The second stage focuses on achieving this objective without overusing or abusing antibiotics. In general, the first stage can be accomplished by rapidly identifying patients with pneumonia and starting therapy with an empirical regimen likely to treat the most common etiologic agents in a particular institution. This requires that the initial antibiotic choice be driven by knowledge of the likely etiologic pathogens and the local patterns of antimicrobial resistance. The second stage involves stopping therapy in patients with a low probability of ventilator-associated pneumonia, focusing and narrowing treatment once the etiologic agent is known, switching to monotherapy after day 3 whenever possible, and shortening the duration of therapy to 7 to 8 days in most patients, as determined by the patient's clinical response and information about the bacteriology, as shown Table 49.1. We will now focus on initial treatment. Optimal treatment of ventilator-associated pneumonia implies that the initial antimicrobial agents could be selected based on an accurate prediction of the responsible pathogens and of their susceptibility patterns, to avoid both ineffective therapy when the pathogen is highly resistant to antibiotics and excessive antibiotic use when it can be covered by a narrow-spectrum agent. Failure to initiate prompt appropriate therapy, i.e., using an agent to which the etiologic organism is sensitive, with the optimal dose and route of administration, has been consistently linked with increased mortality in patients with ventilator-associated pneumonia. Due to the emergence of multi-resistant gram-negative bacilli, such as Pseudomonas aeruginosa, ESBL enterobacteriaceae, and Carbapenemus-producing Klebsiella pneumoniae, and the still important role of gram-positive bacteria, such as methicillin-resistant Staphylococcus aureus, abbreviated as MRSA, empirical treatment with broad-spectrum antibiotics is justified in most patients with a clinical suspicion of ventilator-associated pneumonia. The choice of agents should be based on local patterns of antimicrobial susceptibility and anticipated side effects, and should take into account the antibiotics that the patients have received within the prior 2 weeks, striving not to use the same antimicrobial classes, if possible. Having current knowledge about local bacteriologic patterns can increase the likelihood that appropriate initial antibiotic treatment will be prescribed. A suggested approach for the selection of the initial treatment, as proposed in the European Guidelines for Hospital-Acquired Pneumonia or Ventilator-Associated Pneumonia, is summarized in Figure 49.4. Only patients with a low mortality risk and low multi-drug resistant pathogen risk, such as those without prolonged duration of hospitalization, admission from a healthcare-related facility, or recent prolonged antibiotic therapy, can be treated with a relatively narrow-spectrum drug, such as a non-pseudomonal third-generation cephalosporin. Several published reports have demonstrated the need to adjust the target dose of antimicrobial agents used in treating severe ventilator-associated pneumonia to the individual patient's pharmacokinetics and the putative bacterial pathogens' susceptibilities. Most investigators distinguish between antimicrobial agents that kill by a concentration-dependent mechanism, e.g., aminoglycosides and fluoroquinolones, and those that kill by a time-dependent mechanism, e.g., beta-lactams and vancomycin. Altered pharmacokinetics secondary to an increase in the volume of distribution in critically ill patients can result in insufficient serum beta-lactam concentrations when standard doses are administered, emphasizing the need to monitor peak and trough levels of antibiotics carefully when treating resistant pathogens. Regimens with higher doses than those usually recommended or a prolonged duration of infusion are frequently needed in such circumstances. Development of dosing algorithms based on minimal inhibitory concentrations, patient creatinine clearance and weight, and a clinician-specified area under the inhibitory curve target, as well as therapeutic drug monitoring, might be a valid way to improve treatment of these patients, leading to a more precise approach than provided by current antimicrobial guidelines. Pause the video and carefully scrutinize Figure 49.4 illustrating an empirical antibiotic treatment algorithm before advancing to the next slide. We will now discuss avoiding overuse of antibiotics. The need to ensure that ICU patients with true bacterial infections promptly receive an appropriate antibiotic regimen can lead to many more patients receiving antimicrobial therapy than is actually necessary, because clinical signs of infection are nonspecific. Thus, when a clinical approach to ventilator-associated pneumonia is used, it is important to perform serial clinical and microbiologic evaluations, and to re-evaluate therapy after 48 to 72 hours so that it can be stopped if infection is unlikely. To accomplish this, all diagnostic strategies designed for managing patients with a clinical suspicion of ventilator-associated pneumonia should make explicit the decision tree used to identify patients with a low probability of infection, in whom therapy can be stopped when infection appears improbable. For many patients with ventilator-associated pneumonia, including those with late-onset infection, therapy can be narrowed once the results of respiratory tract and blood cultures are available, if no resistant organism, e.g., Pseudomonas aeruginosa, Acinetobacter species, or methicillin-resistant Staphylococcus aureus, is recovered, or if the isolated organism is sensitive to a narrower spectrum antibiotic. For example, vancomycin and linezolid should be stopped if methicillin-resistant Staphylococcus aureus is not identified, unless the patient is allergic to beta-lactams and has an infection caused by a gram-positive microorganism. Very broad-spectrum agents, such as carbapenems, piperacillin tazobactam, and/or cefepime, should be restricted to patients with infection caused by pathogens only susceptible to these agents. Clinicians must be aware that the emergence of resistant variants may lead to treatment failure when third-generation cephalosporins are chosen to treat infections caused by Enterobacter, Citrobacter, Morganella morgani, indel-positive Proteus, and Serratia species due to the presence of inducible beta-lactamases, even if the isolate is initially characterized as susceptible. The most common reason to use combination therapy in initial management of patients with ventilator-associated pneumonia is to achieve synergy in treating Pseudomonas aeruginosa or other difficult-to-treat gram-negative bacilli. However, antibiotic synergy has been shown to be valuable only in vitro and in patients with neutropenia or bacteremic infection, which is uncommon in ventilator-associated pneumonia. A meta-analysis evaluated all prospective randomized trials of beta-lactam monotherapy compared with beta-lactam aminoglycoside combination regimens in 7,586 patients with sepsis, of whom at least 1,200 patients had ventilator-associated pneumonia. The clinical success rates were similar with monotherapy versus combination therapy, and combination therapy had no advantage in the treatment of Pseudomonas aeruginosa infections. Importantly, combination therapy did not prevent the emergence of antimicrobial resistance during treatment, but it was associated with a significantly higher rate of nephrotoxicity. Based on these data, therapy can be switched to monotherapy in most patients after 3 or 5 days, as long as initial therapy is appropriate, the clinical course is favorable, and microbiologic data do not identify a difficult-to-treat microorganism with a high in vitro minimal inhibitory concentration, as is found with some lactose non-fermenting gram-negative bacilli. Efforts to reduce the duration of therapy for ventilator-associated pneumonia are justified by studies of the natural history of the response to therapy. Most patients with ventilator-associated pneumonia who receive appropriate antimicrobial therapy have a good clinical response within the first 6 days. Prolonged therapy promotes colonization with antibiotic-resistant bacteria, which may lead to a recurrent episode of ventilator-associated pneumonia. A multi-center randomized controlled trial of 401 patients with microbiologically proven ventilator-associated pneumonia showed that the clinical outcomes of patients who received appropriate empirical therapy for 8 days were similar to those of patients who received therapy for 15 days. A trend to greater rates of relapse for short-duration therapy was seen when the etiologic agent was Pseudomonas aeruginosa or Acinetobacter species, but the clinical outcomes were indistinguishable. These results were confirmed in 2 later studies, including a prospective randomized trial of 290 patients evaluating an antibiotic discontinuation policy. Patients for whom a shorter duration of therapy may not be appropriate include immunosuppressed patients, those whose pneumonia was complicated by empyema and/or pulmonary abscess, those whose initial antimicrobial treatment was not appropriate for the causative microorganisms, and those whose infection was caused by non-fermenting gram-negative bacilli and who had no improvement in clinical signs of infection. Many clinicians remain hesitant about prescribing antibiotics for fewer days for patients with ventilator-associated pneumonia, and they prefer to customize antibiotic duration based on the clinical course of the disease and/or using serial determinations of a biomarker such as procalcitonin. The rationale for using a biomarker to tailor antibiotic treatment duration relies on evidence that the inflammatory response is often proportional to infection severity. When that response is absent or low, it might be logical to discontinue antibiotics earlier. Thus, adapting antimicrobial treatment duration to procalcitonin kinetics seems reasonable and has been demonstrated as useful in several randomized trials targeting patients with acute respiratory infection, including 5 trials conducted in the ICU. We will now discuss aerosolized therapy. The recent development of vibrating mesh nebulizers has renewed interest in antibiotic aerosolization in patients with ventilator-associated pneumonia. Their use allows very high concentrations of antimicrobial agents to be achieved in respiratory secretions, including the fluid lining the alveolar compartment, far above those achievable using the intravenous route. However, data in critically ill patients with pneumonia are limited. Most reported experiences are case reports, descriptive studies, or literature review. Moreover, aerosols are likely to reach only ventilated regions of the lungs, and not consolidated areas involved with pneumonia. According to systematic reviews and meta-analyses results, administration of aerosolized antibiotics might increase the likelihood of clinical resolution, particularly in ventilator-associated pneumonia caused by multi-drug-resistant pathogens. However, no significant improvements in important outcomes such as mortality or duration of mechanical ventilation have been consistently documented, and results of a double-blinded, placebo-controlled, randomized trial failed to demonstrate superiority of adjunctive aerosolized antibiotics versus standard of care in any clinically relevant endpoint. Thus, although promising, the widespread use of aerosolized antibiotics to treat pneumonia in the ICU setting cannot be recommended. It should be restricted to the treatment of extensively resistant gram-negative pneumonia susceptible only to antibiotics with limited efficacy and high toxicity when given by the IV route, i.e., aminoglycosides and colistin, or in patients who are not responding to IV antibiotics alone, as a last resort therapy, whether the infecting organism is or is not multi-drug resistant. In these cases, the use of a vibrating mesh nebulizer seems to be more efficient, but specific settings and conditions are required to improve lung delivery. We will now discuss the prevention of ventilator-associated pneumonia. Because ventilator-associated pneumonia is associated with increased morbidity, longer hospital stay, increased healthcare costs, and higher mortality rates, prevention is an important goal. We will now discuss conventional infection control approaches. The design of the ICU has a direct effect on the potential for nosocomial infections. Adequate space and lighting, properly functioning ventilation systems, and appropriate handwashing facilities all lead to lower infection rates. It is important to note, however, that upgrading the physical environment does not reduce the infection rate unless the attitudes and practices of healthcare personnel are also optimized. In any ICU, one of the most important factors is the healthcare staff, including the number, quality, and motivation of medical, nursing, and ancillary members. The team should include a sufficient number of nurses to minimize their movement from one patient to another and to avoid having them work under constant pressure. The importance of personal cleanliness and attention to aseptic procedures must be emphasized at every opportunity. It is clear that careful monitoring, decontamination, and compliance with guidelines for the use of respiratory equipment all reduce the incidence of nosocomial pneumonia. Hand washing and hand rubbing with alcohol-based solutions remain the most important components of effective infection control practices in the ICU. Environmental and patient-oriented microbiologic monitoring facilitates the early recognition of colonization and infection and has been associated with significant reductions in nosocomial infection rates. The focal point for infection control activities in the ICU is a surveillance system designed to establish and maintain a database that identifies endemic rates of nosocomial infections. This information facilitates the recognition of outbreaks, when infection rates rise above the endemic threshold for a specific type of nosocomial infection. An antibiotic policy that restricts the prescription of broad-spectrum agents and inappropriate antibiotics is of major importance. Better use of antibiotics in the ICU can be achieved by implementing strict guidelines, avoiding the treatment of patients who do not have bacterial infections, using narrow-spectrum antibiotics whenever possible, and reducing the duration of treatment. Similarly, transfusion of red blood cells and other allergenic blood products should follow a strict policy because several studies have identified exposure to allergenic blood products as a risk factor for postoperative infection and pneumonia. Next we will discuss specific prophylaxis against ventilator-associated pneumonia. Specific strategies aimed at reducing the duration of mechanical ventilation, a major risk factor for ventilator-associated pneumonia, such as improved methods of sedation, use of protocols to facilitate and accelerate weaning, mobilizing patients as soon as possible, and using low tidal volume with adequate levels of positive end expiratory pressure, are integral parts of any ventilator-associated pneumonia prevention program. All are based on the application of strict protocols. Similarly, non-invasive positive pressure ventilation using a face mask should be used whenever possible. Some very simple, safe, inexpensive, and logical measures may have beneficial effects on the frequency of ventilator-associated pneumonia in mechanically ventilated patients. These include avoiding nasal insertion of endotracheal and gastric tubes, maintaining the endotracheal tube cuff pressure above 20 cm of water to prevent leakage of bacteria around the cuff into the lower respiratory tract, promptly reintubating patients who are likely to fail extubation, keeping patients in the semi-recumbent position when enteral nutrition is used, removing tubing condensate, and providing adequate oral hygiene with sterile water alone, even though the level of evidence for the efficacy of these measures is low. Continuous or intermittent suctioning of oropharyngeal secretions has been proposed as a means to avoid chronic aspiration of secretions through the tracheal cuff of intubated patients. However, an updated meta-analysis of subglottic secretion drainage reported no impact on duration of mechanical ventilation, ICU length of stay, or mortality, casting some doubt on the efficacy of such a measure. Investigators have also proposed a number of innovations in endotracheal tube cuff materials, shape, and design, as well as more consistent and frequent cuff pressure monitoring, in order to prevent micro-aspirations of microbe-laden secretions along the vertical microfolds that develop along the endotracheal tube cuff. Unfortunately, none of these innovations have thus far been proven to prevent ventilator-associated pneumonia or improve objective patient outcomes. Gastric colonization by potentially pathogenic organisms increases with decreasing gastric acidity. Thus, medications that decrease gastric acidity, antacids, histamine 2 blockers, can increase the gastric bacterial burden and increase the risk of ventilator-associated pneumonia. However, whether stress ulcer prophylaxis increases ventilator-associated pneumonia incidence is still debated. Cragg and colleagues randomized 3,298 patients in 33 European ICUs to daily intravenous pantoprazole versus placebo. Patients randomized to pantoprazole had a lower rate of clinically notable gastrointestinal bleeding, 2.5% versus 4.2%, but no difference in the rates of red blood cell transfusions, pneumonia, Clostridioides difficile infections, or 90-day mortality. While this trial somewhat tempers the concern that stress ulcer prophylaxis may increase the risk of pneumonia in critically ill patients, it simultaneously fails to provide clear evidence that stress ulcer prophylaxis improves objective patient outcomes. Oral care with chlorhexidine was considered until recently as an important measure for preventing ventilator-associated pneumonia. However, new data have questioned its true efficacy and safety. While meta-analyses of randomized trials have reported that oral care with chlorhexidine lowers ventilator-associated pneumonia rates by about 30%, this signal is only evident in open-label studies. If one restricts the meta-analysis to double-blind studies, the signal is diminished and no longer significant. Furthermore, no benefit in duration of mechanical ventilation or mortality has ever been demonstrated. There are also some concerns regarding a possible increased risk of mortality and ventilator-associated events, as noted on meta-analyses of randomized trials and several observational studies. Selective decontamination of the digestive tract, abbreviated as SDD, includes a short course of systemic antibiotic therapy, such as sfotaxime, trimethoprim, or a fluoroquinolone, and topical administration of non-absorbable antibiotics, usually an aminoglycoside, polymyxin E, and amphotericin, to the mouth and stomach, to eradicate potentially pathogenic bacteria and yeast that may cause infections. Since the original study published by Stoutenbeek and co-workers in 1984, which demonstrated a decrease of the overall infection rate in patients receiving the selective digestive decontamination regimen, more than 40 randomized controlled trials and 8 meta-analyses have been published. All 8 meta-analyses reported a significant reduction in the risk of ventilator-associated pneumonia, and 4 reported a significant reduction in mortality. Several prospective, randomized, controlled trials, all performed in ICUs with low rates of antibiotic resistance, that were large enough to show a significant survival benefit in selective digestive decontamination treated patients have been published. All were in favor of treatment with selective digestive decontamination, the largest and most recent one demonstrating a relative decrease in 28-day mortality rate, odds ratio 0.83, with a 95% confidence interval 0.72 to 0.97, and an absolute survival benefit of 3.5%. Even so, Widespread use of selective digestive decontamination in ICU patients remains controversial. The major concern with use of selective digestive decontamination is that it can promote the emergence of resistant bacteria, particularly gram-positive bacteria such as methicillin-resistant Staphylococcus aureus. This is likely to be an even greater problem in ICUs with a high baseline rate of resistance. In contrast to what was expected, most studies that have evaluated this issue showed a lower incidence of colonization with resistant bacteria in selective digestive decontamination treated patients than in control patients, even after many years of utilization, possibly because decontamination prevents some infections and thus saves some patients from needing treatment with intravenous antibiotics. Nonetheless, active surveillance for resistant pathogens among all ICU patients, not just those receiving digestive or oral decontamination, suggests that selective digestive decontamination is associated with small but significant and sustained increases in the unit-wide prevalence of antibiotic-resistant organisms. The most recent European guidelines on the management of hospital-acquired pneumonia and ventilator-associated pneumonia issued a weak recommendation in favor of selective oral decontamination alone, not selective digestive decontamination, and only for settings with low rates of antibiotic-resistant bacteria and low rates of antibiotic consumption. The recent publication of a trial that assessed the value of oral care with 2% chlorhexidine versus selective oral decontamination versus selective digestive decontamination, each compared with standard of care, in a cluster randomized crossover trial among 13 European ICUs with moderate to high rates of antibiotic resistance at baseline supports this recommendation, having found no differences between arms in either ICU-acquired bloodstream infections with resistant organisms or 28-day mortality. And now we will focus on implementing a structured prevention policy. The application of consistent evidence-based interventions to prevent ventilator-associated pneumonia has been highly variable from one ICU to another and is often suboptimal. Furthermore, no single preventive measure can succeed alone, emphasizing the need to use multifaceted and multidisciplinary programs to prevent ventilator-associated pneumonia. Such programs are frequently referred to as care bundles. A care bundle is a set of readily implementable interventions required to be undertaken for each patient on a regular basis. The goal is for every intervention to be implemented for every patient on every day of his or her stay in the ICU. Compliance is assessed for the bundle as a whole, so failure to complete even a single intervention means failure of the whole bundle. The interventions need to be packaged in such a way that compliance is readily assessed, which usually means that no more than 5 interventions are included in each care bundle. The performance goal is to achieve over 95% compliance routinely. Care bundles make it possible to introduce evidence-based preventive measures, including achieving appropriate nurse staffing levels, avoiding intubation, and initiating specific strategies aimed at reducing the duration of mechanical ventilation, as described above. Several studies using quasi-experimental design have confirmed the usefulness of this strategy for preventing ventilator-associated pneumonia in the ICU. The lack of methodologic rigor of the reported studies, however, precludes any conclusive statements about care bundle effectiveness or cost-effectiveness. The exact set of key interventions that should be part of the ventilator-associated pneumonia prevention bundle is also not currently known, nor are factors contributing to its success. Successful ventilator-associated pneumonia prevention requires an interdisciplinary team, educational interventions, system innovations, process indicator evaluation, and feedback to healthcare workers. As shown in a recent study, simply having a checklist available for reference without consideration of a robust implementation and adherence strategy is unlikely to maximize patient outcomes. In the United States, the Centers for Medicare and Medicaid Services has proposed ending hospital reimbursements for care made necessary by preventable complications, including nosocomial infections, aiming for a zero ventilator-associated pneumonia rate. Although this plan may have the desirable consequences of improving the quality of care, it also may penalize hospitals that admit high-risk patients and inadvertently encourage institutions to underreport ventilator-associated pneumonia or to overuse antibiotics, thereby favoring dissemination of multi-drug-resistant microorganisms. This possibility further underscores the need to evaluate all new strategies potentially aimed at preventing ventilator-associated pneumonia by comparing them to current best clinical practices. Finally, we will discuss a few key points. 1. Ventilator-associated pneumonia, abbreviated as VAP, is associated with mortality in excess of that caused by the underlying disease alone, particularly in the case of infection due to high-risk pathogens, such as Pseudomonas aeruginosa and methicillin-resistant Staphylococcus aureus, and/or when the initial therapy is inappropriate. 2. The predominant organisms responsible for infection are Pseudomonas aeruginosa, Staphylococcus aureus, and Enterobacteriaceae, but etiologic agents differ widely according to the population of hospital patients, the duration of hospital stay, and prior antimicrobial therapy. 3. Because even a few doses of an antimicrobial agent can negate results of microbiologic cultures, pulmonary secretions in patients suspected of having developed ventilator-associated pneumonia should always be obtained before new antibiotics are administered. 4. The initial approach to antimicrobial therapy involves administering broad-spectrum antibiotics to avoid inadequate treatment in patients with true bacterial pneumonia. 5. The management of antibiotic therapy for ventilator-associated pneumonia should optimize care without overusing and abusing antibiotics by stopping therapy in patients with a low probability of ventilator-associated pneumonia, streamlining treatment once the etiologic agent is known, switching to monotherapy after days 3 to 5, and shortening duration of therapy to 7 to 8 days. As dictated by the patient's clinical response to therapy and information about the bacteriology of the infection. 6. Evidence-based preventive measures include staffing nurses at appropriate levels, avoiding intubation by using non-invasive ventilation whenever possible in suitable populations, and reducing the duration of ventilation by maintaining low tidal volume ventilation and sedating at minimal levels coupled with paired daily spontaneous awakening and breathing trials. 7. Current evidence is insufficient to favor either a clinical or invasive approach to diagnosis of ventilator-associated pneumonia regarding clinical outcomes, although evidence indicates that the invasive approach can reduce use of antibiotics. Thank you.